Tēnā koutou, tēnā koutou, tēnā koutou katoa, namaste, ni hao ma. Warm greetings, everyone. Welcome to this special webinar of the Health Promotion Forum of New Zealand and the Asian Network Incorporated. This is one of our collaborative effort exercises to bring more attention and greater awareness and understanding of the health challenges that our Asian communities are facing. And I'll say more about it in a minute. But by way of karakia, let me share with you these inspirational words to center our attention, our mind and spirit. You know, we live in times of war and crisis across the world, while Mother Nature is collapsing because of our human follies. When a thought of war comes, oppose it by a stronger thought of peace. A thought of hatred must be destroyed by a more powerful thought of love. May all people unite in harmony so that they may become as the rays of one sun, as the waves of one ocean, and as the fruit of one tree. May all people unite in harmony so that they may become as the rays of one sun, as the waves of one ocean, and as the fruit of one tree. So the recently released Asian Health in Aotearoa Report 2024 reveals some worrying health trends among Asian communities in our country. And our speakers, Mr. Vishal Rishi and Dr. Zhenqiang Wu, they will discuss these findings and explore with us participants how health promoters and other health professionals, of course, can contribute to addressing the well-being of our diverse communities. So we will start with Vishal, who is the CEO of TANI, the Asian Health Network Incorporated. Vishal will provide us with some background about TANI and, of course, the health of the Asian communities to provide a context that will help us understand the significance of this latest report. As I understand, this is the second report, and it is very timely for us to increase our awareness and therefore build our capacity and competencies how to deal with these issues. The Asian communities, by way of rights, have the same rights as we all have to Hawara. And that's, of course, the theme, the logo of the Health Promotion Forum as well. Hawara, everyone's right. And it's timely that we visit this area of knowledge and challenge in our community to create greater understanding and awareness and sharpen our tools. And I'm sure this workshop will contribute significantly to that. But firstly, let me, on your behalf, express my gratitude to our two wonderful speakers for you today. Thank you, Vishal. Thank you, Dr. Wu, for allocating time out of your very busy schedules to be with us. So they will take about half an hour each or so, and then the floor will be open for questions. So listen proactively and prepare questions as they come to mind. But let me go back and invite Vishal to start with you, Vishal. The floor is yours.
Kia ora koutou, tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko Vishal Rishi aho, no Inya aho originally, migrated here 22 years ago. Ki Pukita Papa, Tamaki Makaurau, aho e noho ana. Tēnā koutou, tēnā tātou katoa. Thank you, Sione. Thank you, lovely Howrah team, Health Promotion Forum of New Zealand, giving us the opportunity to talk about a very significant concern and the issue about Asian health today with our whānau and our co-workers and the workforce who is attending today. But what I have learned is not only the audience today, but this recording will be made available on YouTube to view it later as well. So that is a very great korero and gesture from Health Promotion Forum of New Zealand. Thank you very much for giving us the opportunity to speak. Yeah, coming to this topic, which is really very close to our hearts. When I say our hearts means I'm talking about the Asian Network and myself personally. Since I arrived in New Zealand, I have been associated with the broader Asian communities and working together with the communities and trying to act as a bridge between the broader Asian communities and the health service providers so that the Asian communities can have better access to public health and social services in New Zealand. And this was one of our key visions and objectives of the Asian Network Incorporated as well. We are progressing this from last more than 24 years now. Asian Network was formed in year 2002. So I think without further ado, I would like to share few slides and then I will pass it on to my co-presenter, who is the lead author for the Asian Health in Aotearoa Report as well, Dr. Zhenqiang Wu, who is with me. Dr. Wu, would you like to just briefly introduce yourself, and then meanwhile, I will just try to share my slides, please.
Cool. Kia ora, everyone. Good morning. I am Zhenqiang Wu. I'm a senior research fellow at Auckland University. I'm also a biostatistician at Epidemiology and Biostats Department. As Vishal just mentioned, I am one of the co-authors of our recent Asian Health in Aotearoa Report. Our other two co-authors were Professor Robert Scragg and Mr. Sally Wong. Yeah, that's about me.
You're muted,
You're
Vishal.
mute, Vishal.
Trying to share now. Sorry, can you see the slides? No?
Yes.
Sorry, can you see the slides?
Yes.
Yes.
Okay. Sorry, I can't see them. Okay. Is it visible to you, all of you?
Yes.
Okay, perfect. Yeah, so as I mentioned, apologies for this technical, there were 3 slides open at the same time. TANI, as I mentioned, is the Pan-Asian Health and Social Service Provider working for the betterment for the Asian community's better life and well-being. TANI was established in year 2002. And since then, we have been progressing with our visions and also as we have gone along the journey, working with the broader Asian communities, the more we get to work with the Asian communities, the more we learn every day. I'm still learning. So I'm not expert, but still have a gist of the information and the issues that our broader Asian community faces in our health and social service perspective. Not only that, but I would like to mention all Asian people in New Zealand, living in New Zealand, are not healthy and wealthy. So that notion that Asians' health is all good, I think this is the kind of concern which we are going to uncover today with this particular report, which we have published. We work towards empowering Asian communities and respond to the emerging health and well-being social needs. And we act as a bridge between the health service providers and the broader Asian communities. I would like to touch base on this is my favorite slide, that we talk about the term Asian, how the term Asian is used in this context in New Zealand, and when it comes to health issues and health determinants of health, then this definition becomes much broader. So the term Asian encompasses people from the vast area, Japan in the east and Afghanistan in the west, and people self-identify from Asian origin or their cultural heritages. So this is a very open-ended kind of a definition Stats New Zealand uses in New Zealand. But when it comes to the health and dealing with the health concerns and the issues, this definition becomes a little bit broader. For example, a Fijian Indian, fourth generation Fijian Indian coming to New Zealand, they might tick themselves as Pacific. And then they may not tick anything else. So what does that mean is that they may not be counted in the health stats for that particular census. But their risk of getting diseases like CVD, diabetes, high blood pressure, hypertension, that remains the same, or maybe more in some cases, than native coming from India, Indian from Asian continent. So same way, the definition goes broader. If a South African Indian, for example, which does not technically may fit into this definition over here that you can see on the screen, but when it comes to health issues and concerns, that South African Indian will have the same genetic composition and will be very prone to having diabetes, CVD, and high blood pressure. So I'm just giving you as an examples, but there will be a lot of other examples from East European countries as well. So when our health planners, health champions plan the activities, so they need to use this lens to probably design the services and the products that work better for the broader Asian communities. Coming to the stats, this is very interesting stats and the recent stats which has just come out a couple of months ago, and are really astonishing about the Asian community. But what we are going to touch base today would be, especially the report has referenced the 2018 statistics more than the 2023, because the report was already finalized just before the stats were released. But apart from that, I think I will touch base on the very current stats in a couple of bullet points, but give you the trend of how the Asian population have increased over the years. As you can see on your screen, in 1986, there was less than 2% of Asians living in New Zealand. And by 2013, it was about close to 12%. And between 1986 to 2013, Asian population has grown nearly 9-folds. And total number of people identifying as Asian in 2018 grew by 50% from 2013, as you can see. But this was followed up very closely by MILA populations, Middle Eastern, Latin American, African groupings, which was 49.8% increase. followed by Maori populations, which was close to 30% increase, and then Pacific population close to 30% increase as well. But for Asian ethnic groups experiencing a growth of at least 50%. So this is a very big increase in the growth, especially related to the ethnicities within the sub-Asian categories, which you can see on the screen, is Indian population, that is close to 54% increase, and Filipino population is 80% increase. So we need to be mindful when we design our programs at a strategic level, that what sort of population we are dealing with here. Vietnamese, 50% increase. Pakistani population is close to 90%, close to 88% increase, which is enormous, which means the Pakistani population might have doubled in those years. So Afghani population 53, and Nepalese population is the increased the most, which is close to 128%. So which is more than doubled. Again, this particular graph, a table which you can see on the left-hand side of the screen is from 2018. But I'll give you a slight update on this would be the recent stats. I think the Indian population has surpassed the Chinese population now. It's close to 300,000 people Indian, followed by 280,000 Chinese community, followed by Filipino, Korean, and so on. And currently, the Asian population is nearly 18% of overall New Zealand population, and it's projected to increase by 26% by 2035. When we say 18% overall New Zealand population, but when we do the broader ethnic population calculations with the latest stats, which we have been released, including Mela population, including refugee and former refugee populations, all ethnic except Māori and Pacific populations, we are sitting at around 21% of overall ethnic populations in New Zealand, 1/5. So which is a huge population, but between that 21%, close to 18% is Asians. So Asian dominate the ethnic population of New Zealand. So we cannot, when we talk about ethnic population, so Asian is the largest, the biggest chunk. But again, when it comes to health and the other social issues of other ethnic, less visible Asian communities and the other communities, they face much more challenges than we will touch base on those challenges within this presentation today. So nearly 34% of Aucklanders consider themselves as Asians, and more than 80% of Asian population is born overseas. So which means more than 80% of current Asian population, English is the second language, or maybe third for some. Of course, immense diversity within Asian subgroups, and that brings us a lot of challenges, but opportunities at the same time. So we can touch base on the challenges and opportunities towards the end of the presentation today. Hence, complex health and well-being and social issues. And that is where everyone, like mainstream, may get confused or scared. Oh no, it's too much diversity. Oh, we need to unpack. So there's a chicken and egg situation. Always when we talk to the decision makers, they say, oh, Asians are so broad definition, so big category. But we have enough data, enough information about various subcategories over the years that we can at least start addressing some of them, rather than waiting for another 20 years. Then once we get all the stats, and data is never going to be accurate 110% at all. So which means we need to start from somewhere. That is what we always tell our decision makers. So I think I will just stop here, and I will invite probably my colleague, Dr. Zhenqiang Wu, to present the findings of the recently released Asian Health in Aotearoa Report. I would like to mention before Dr. Wu comes on to explain that this is the second such report that the Asian Network has commissioned. But overall, this is the fourth report that has been released. But this is the very first one that has analyzed the 20 years of data of New Zealand Health Survey. So this is one of the recent ones, and we have taken out the Asian respondents from last 20 years and then analyze the data and the trends coming through the report. So I would like to mention how vital and important piece of work is this. And now I will pass it on to my colleague, Dr. Zhenqiang Wu.
Cool. Yeah, I'll probably just share my screen as well. Can you all see my screen?
Yes.
Okay, cool. Yeah, Kira, everyone. I am Zhenqiang. Thank you for all your introduction, Vishal.
Sorry, Dr. Wu, can't hear you.
Okay. Yeah. How about now?
Oh, yeah.
Okay, cool. Yeah, sorry for the technical issues. Today, I will very quickly walk you through the method and some of the key findings from our recent Asian Health Report in New Zealand. So as Vishal just mentioned, this is actually the fourth Asian Health Report in New Zealand. The last one was published in 2016 with data up to 2011 to 2013. This current report updates the previous reports with data up to 2021. That means we have another 10 years of data in the latest report. So regarding the full report, I can say there is a link in the chat, so you can easily download the full report. But if it's not working, just let me or Vishal know. We are more than happy to share a little bit of background about the New Zealand Health Survey. So the data sources will come from the New Zealand Health Survey from 2002 to 2021. So the New Zealand Health Survey, using the cluster sampling from New Zealand households, it is designed to oversample Asian, Maori, Pacific to ensure sufficient sample size for ethnic-specific analysis. So if the participants have multiple ethnicity, we use the following prioritized ethnicity to decide the order, followed by South Asian, Chinese, other Asian, Maori, and Pacific, European, or other. So that also means our Asian Health Report is not just about Asian. We also have plenty of results for Maori and Pacific people. So as New Zealand Health Survey, that's designed to be a representative sample for all New Zealand population. That means all the percentage and stats in our report will be New Zealand representative. The New Zealand Health Survey information collected separately for children aged 14 years or less, or adults aged more than 15 years old. We're collecting the demographic, health behaviors, health conditions, and health service utilization. So just give you some sense of the analyzed sample size in our reports. That's roughly 2,000 adults and 1,000 children in the latest two New Zealand Health Survey combined. The numbers looks quite reasonable. So in the next few minutes, I will very quickly go through the key findings from our Asian Health Report. Some of them is very varying, but others will be quite pleasing for our Asian community. So as Vishal just mentioned, Asian community is fastest growing ethnic groups in New Zealand. So it's roughly 17% for children and roughly 15% for adults. When you have a look at the trends in the last 20 years, you can see very clearly increasing trends in all Asian community or Asian subgroups for both children and adults. So this slide shows some demographics of Asian and Asian subgroups in New Zealand. We can see from the left side figure the age 65 or more. We can there is a slightly increase regarding the people more than 65 years or older in Asian as a group and Asian subgroups. But when we compare with European, we can say it's still much lower in the people aged 65 or more. That's saying our Asian community is still a little bit younger together with more than Pacific when we compare with the European. The right side figure shows the living years in New Zealand in adults. We can say people tend to living longer in New Zealand when we compare with 20 years ago. There is a very clearly increasing trend, people living more than 10 years or New Zealand born. So this slide shows the socioeconomic status of our Asian community and Asian subgroups. Pleasingly, we can say the education level is pretty high in our Asian community. When we say the people with bachelor or higher degree, that's roughly more than 50% people have a bachelor or higher degree. It's much higher than all three other ethnicity groups. Regarding the living area, here we use New Zealand Deprivation Index to represent the living area. We can say, we can pleasingly see there is a decreasing trend in South Asian, Chinese, and other Asian for people living in the high deprivation area. Specifically for South Asian, other Asian, you can say roughly 50% people living in quintile 4 and 5, that's a high deprivation area, is much higher than European other. And we see very similar figure for Mali and Pacific. It's around 60% for Mali and Pacific 70%. It's almost double than European other. So regarding the government income support, here we reference like unemployment payment or retirement pension. We can see the trends in government's income support is kind of like decreasing in the last 20 years for Asian and for Asian subgroups. And it's much lower than all three other groups when we compare with European or other. After adjusting for age and gender, we see very similar figure for Asian as a group and Asian subgroups is always unlikely to receiving government income support. So now things become a little bit serious. Ethnic discrimination is still very prevalent in our Asian community. For example, the Chinese is more than 40% people reported as victim of ethnicity motivated attack. That's including verbal or physical attack. In the last 20 years, we see a slightly increasing trends in ethnic discrimination. When we have a look at treated unfairly due to ethnicity, we see very similar figure. It's roughly 15% in our Asian community, and it's much higher than European and other groups. So I think the most important message for this one is there is no improvement in the last 10 years. You can say since 2011, there is no improvement for treated unfairly or victim as ethnically motivated attack. The trends in nutrition is also concerning. for fast food intake more than 1 time per week in children, we can see there is a very clearly increasing trends in Asian community and Asian subgroups. When we compare with the European or other, it's probably a little bit slower, but when you have a look at the trends, there is very clearly increased trends. I think the figure will be very similar for fruits and vegetable intake, 5 times or more a day in adults. You can say the recommended proportion is decreasing in the last 20 years. When we compare with European or other, it's around 45%. But when we have a look at our Asian community, it's only around 30%. So it's much lower than European or other ethnic groups. So this is probably the most concerning slide I show you today, the trends in obesity. Here, just to clarify, here we use ethnic specific definition for obesity. I put a reference on the bottom. We use the WHO recommendations. And consistently, we see an increase in trends in the last 20 years for both women and men. It's around 60% in South Asian in women and around 40% in other Asian in women. When we compare with European or other, it's also much higher than European or other group. So as promised, I also show you some promising results. That will be the trends in tobacco smoking and alcohol drinking. Here, we only show the figures for men, but that's a very similar figure for women. So we pleasingly say there is a decrease in trends in current smokers in men. Also, we saw the drinking alcohol in the last 12 months. There is a slightly increasing trend, but fortunately, when we compare with the European or other groups, it's still much lower. It's around 60% in our Asian community, around 28% lower in the European or other ethnic groups. So this figure shows the relative risk of medical conditions when we compare with European or other. It's like so the children, so the eczema and asthma, we can say the figure is kind of like mix. For eczema, we say the Chinese, other Asian, together with more Pacific, is around 50% higher risk when we compare with European. But when we have a look at asthma, it's very similar in our Asian community and Asian subgroups when we compare with European or other, but we see a very high risk for Mongolian and Pacific groups. So this is the figure of the medical conditions for adults more than 25 years old. It's very concerning regarding the diabetes. We can see very high risk of diabetes in South Asian, other Asian, together with Mongolian and Pacific. For South Asian, we can say is 3 times more likely to be a diabetes. And regarding the asthma, we say a lower risk asthma in all Asian subgroups. It's probably because of a low smoking rates in our Asian community. So regarding the access to care, we can say trends in health service utilization in New Zealand. From the left side figure, we can see people having health practice to save and unveil. There is a slightly increasing trends in the last 20 years. However, when we compare with more Pacific European, that's roughly 95%. But however, Asian is only around 90%. So that tells us we still have quite a lot of room to improve the access to primary care. When we have a look at the attended public hospital, that's referring to secondary care, we can see there is slightly increase in South Asian and other Asian. But when we compare with more Pacific and European, we can see the numbers still much lower than other ethnic groups. definitely a lot of room to be improved for access to care. So regarding the access to oral care, in the latest 2 surveys, we see very similar figure for children and adults. All 3 Asian groups are lower than the European and more Pacific group. Very similar figure for adults visit oral health care in the last 12 months. It's around 30% for Asian community, but it's around 50% for European or other group. Yeah, we'll do a very quick summary for the key findings. So firstly, the Asian community and Asian subgroups in New Zealand continues to increase in size, and ethnic discrimination is remain very prevalent in Asian population, especially for the Chinese community. The trends in health behavior is mixed. We can say the risk factor for cardiometabolic disease have worsened. For example, the fast food intake, the fruits and vegetable intake, and the body size. But we say the smoking is declining. Also, the alcohol intake is slightly higher than 20 years ago, but still way lower in all other 3 ethnic groups. We also say the cardiometabolic disease are increasing in Asian people, like diabetes, high cholesterol, and high blood pressure. The following 2, I didn't show you a figure, but that's increasing in Asian people. But we say some diseases are lower, like asthma, arthritis, and depression in our Asian subgroups. Regarding the access to primary and secondary care, we say a very consistent figure. Asian people less likely to have a Euro primary health care provider, less likely to use public hospitals, and less likely to have access to oral health. I think more importantly, the current report found very similar figures compare our previous report, except we see a more robust trend figure by accumulating 20 years of data. So we probably really need to think for what should we do next or the next few years to improve the Asian health outcomes. So the last but not least, I acknowledge our co-authors, Professor Robert Scragg and Ms. Sally Wong, also our very supportive founders, TANI, Stats New Zealand, Auckland University, and Ministry of Health. I'll probably just stop here. Thank you.
Thank you, Dr. Wu, and thank you, Vishal, as well, for that background and context that you provided earlier. It makes the report summarized and presented by Dr. Wu more meaningful and easier to relate to. Very comprehensive, but your last point, that is the similar trends in the last report, 2016. I have had a look at that report earlier on for other purposes, but it's quite concerning to see it's consistent. So it's very timely for us to have a dig into the report, and for the health promotion community, both providers and the practitioners, the workforce, it's very important for us to be aware of this, because among other things, and first and foremost, health promotion is about starting where health is, at home, in the workplace, at school, and it's about promoting well-being and preventing diseases and protecting illnesses and enabling communities to take charge, greater control of the determinants of their health. And your report has articulated very clearly those challenges, and in comparison to other groups. I also note that what you said, that the report can be also useful for other groups. It's not just Asian. Thank you, for that as well. I hope that we have some questions on the floor. We have enough time to really dig deep to any issues that have been brought up by our presenters for us to look closely at. More importantly, what are some thoughts in our heads, not just as the workforce, health promotion workforce, practitioners who are present here today, but also the thoughts of the speakers. What can we do together? Because we are a one national community. And I myself have been following the health and well-being of the Asian communities, as Vishal knows. We have been working hard together to advocate as our responsibility as health promoters for policy at policy level, at organizational level, to see some policies and actions in place to promote and prevent rather than to treat, after the disease is upon us and within us. But let me stop my remarks there, and I have asked Lavinia, a member of our team, our communications advisor. Lavinia will ask some questions first, while our participants refine their questions and put them on a chat, and Lavinia can ask on your behalf your questions to our presenters.
Thank you, Sione. I have a question from Trish, one of our participants. Trish's question is, please, can you also comment on the efficacy of translated resources and information for service users? I think either you, Dr. Wu or Vishal, might be able to answer this question. It's in chat.
Sorry. Yes. Thank you. Thank you, Trish, for the question. So the question is, correct me if I'm wrong, Lavinia, whether there's a need for translating the resources.
I think the question is more how efficient translated resources and information.
I don't know if they do visits. I think. Vishal, thank you so much. Just be quite good to understand. We get, from a service provider perspective, we get a lot of feedback that we need to put our resources translated into multiple languages for multiple groups, and that's quite a tall. That can be quite a tall order for an NGO or a provider to do that. And just sometimes I wonder about when that information gets shared, particularly if we're coming perhaps from the hospice and palliative care perspective. I wonder then I just wonder about the efficacy of the information in that, the cross divide, the great translation space.
Yeah.
Thanks, Vishal.
Thank you. Thanks, Trish, for the beautiful question. I think that is the one of the significant piece of work if we consider it at a national level. But I would like to break it down to national, regional, and local level. I will take an example of COVID, for example. So in COVID, a lot of resources were put into the COVID website, response website, which was a national portal. And a lot of resources were translated into a number of languages so that people have an equitable access of all the resources in their native languages. So there was a challenge with that approach at a national level, was that website was so beautifully designed, everything was so good. We as providers, even it was very difficult for us to navigate through the translated resources. So what happens then when our community started to approach us about bullet point information, like not 9 pages, not 7 pages. They wanted a bullet point, 1 or 2 pager information so that they can quickly respond to the needs they were having or the challenges they were facing. So what we did that time was we pulled out the translated bigger, longer resources from there and converted them into the language, not only translated, but the language that community understands. Not the technical language, not the jargony language, so that people can easily understand and make changes to how they have to respond to their needs. So these are the things which have worked really very well during that time. So when it comes to NGOs or palliative care or relevant resources, I would say please use the people like us, or there are a few other smaller NGOs who do that on voluntary basis. But on the other side, there will be a very small cost, but it won't be a hugely big cost. But that's, again, it is just a patchwork, I would say. Translating few resources, few flyers here and there is not going to make people's life better. But at least they will have some information what they can do. That's it. But I think if we think about a strategic level, we have to think strategically at a longer run. I will give you an example of Asian Health Services and Waitemata District Health Board that was led by Dr. Dale Bramley when he was the CEO of Waitemata District Health Board. That was the time when it was set up. Su Lim and the Grace Wong and Li Fong and all those team members, the whole team was set up that time. So that is the only team I can see nationwide has managed to do something in Asian health because there was dedicated higher management, bureaucratic will was there. To make this change, to champion that within the organization. Although there wasn't any big, huge political will, but there was champions like Dale Bramley, Dr. Dale Bramley, who championed that kind of thing, and they make sure that the Asian population, Asian initiatives is resourced to up to a level that they can make a difference to the communities. But that is, again, it is just a one pocket of health, or the Asian health we are talking about. Answering your question, yes, translating resources is a great way to at least start responding to the needs, I would say. But that is not the end. It is just a basic thing what we can do at our levels. Yeah.
Thank you, Vishal. I appreciate it.
Thank you, Vishal. I have another question
Yeah.
from Leanne. Leanne asks, are there any measures being proposed to curb the rising rates of obesity in the Asian community?
No. Answer is no. So why I'm so blunt and upfront with that answer is because, as I've mentioned earlier, we as a society are very reactive to respond to the issues that are highlighted either in media or are politically motivated, right? But what we see in the data, not from this report, but from the previous report and the previous report and the very first report, the trend is similar, but the scale is increasing. Right. So what I mean is, when there is, I shouldn't say, but I'm happy to say, because these are the challenges why the sector is not moving in a way that it should have responded to the equity issues, is because of the political will. There is no visibility of Asian health in Aotearoa, very less visibility. Even if there is one line there, it has no meaning, in a way that there are no resources, no strategy, no plan attached to it. We are not asking, we should have strategy. Okay, we don't have strategy, leave it. It's too complex, too political. Oh, where is the plan? There is not even a plan to deal with the broader issues various Asian population is facing. So one is that sort of a action probably oriented political will, which is not there. Okay, what else we can do? Then it comes to the bureaucratic will. The CEs of Health New Zealand or the directors of our health sector, they being the champions who have the responsibilities of equity, ensuring equity for all, good health for all, they should be championing and saying and advocating, oh no, this is required in their locality, in their region. This needs to be addressed because there is data. And what we can see in the current report, I would like to mention here, is just tip of the iceberg. It is just the reported New Zealand Health Survey data. It is just tip of the iceberg. There's a huge mountain underneath. Why I can say that? Because we work in the community. We see that every day. We see that every day, every minute, the challenges people face. Maternal health, mental health, maternal postnatal health of Asian women. There are lots, although we have a women's strategy in the PAIORA, one of the strategies is women health strategy, but we don't see any visibility of Asian women in there as well at a national level. So which means there is not a blind spots we are talking about. We are talking about everything is black out there. You know, there is nothing, not even no one is even talking about the challenges Asian community is facing. So that is the problem. And then the third and the last layer I would like to mention who can make a big difference is you and me, right? The people who are here today and people in our workforce who deal and work with the Asian community every day. We see those challenges. My heart cries when I hear the news when a top manager of a hospital says you are not allowed to speak in your own language to the patients. That is devastating. Where is this society going? I am failed to understand. You know, you might have seen in the news just a couple of days, one day ago, right? And it has happened again in another hospital as well. We are talking about addressing in a culturally appropriate manner. And on the other side, the leaders, the managers, the general managers are passing these statements that you are not allowed to speak in your own native language to the patients. So there is a big mismatch out there in the understanding what we are even talking about here today. So I will just stop there, but I can keep talking on this because I'm so passionate about addressing equity issues, whether it's Māori, Pacific, or Asian communities, you know, yeah.
I have another question from Trish again, who asks, what do we think may be the reasons for the lower number of Asian peoples registered with a primary health provider?
Trish, very good question again. Different health systems, where the different, okay, I'll start from, we all Asians come from different, experience different health system in our native countries. One, the new migrants who arrive here are generally better lot of the other Asian members who are left in their own country, because when we get immigrant visas, we are well scanned, we are well inspected clinically and everything. Over the years, due to healthy immigrant effect, maybe 7 to 9 years, our health starts to deteriorate, right? So when the longer the Asian or any immigrant live in a country, the health starts to deteriorate, right? And why that happens is that happens due to lack of knowledge, a different health system, acculturation issues, different lifestyle, stress, and other socioeconomic factors. That is one big chunk, big part. So why in the initial years people do not enroll, because they are already healthier than other people. But on the other side, the cost is another factor. One, they don't know where to go. Another is cost. And the third is the excess enrollment is not that simple. Because in our countries, most of the Asian countries, when you fell sick, you just knock on the doctor's door, and doctor is there. If that doctor is not available, you go to another doctor's clinic, right? It is easier when you feel sick, doctor is there. But now, what in the recent 5 to 7 years, we have seen when you need a doctor, you don't get to see the doctor in New Zealand, right? When you need to see a GP, you don't see your GP because you're sick today, but you get your GP appointment 2 weeks later. So that does not register in our mind. It doesn't make sense. When you're sick, you can't see doctor, and by the time your appointment comes in, you're already well to go, right? So there are lots and lots of multiple layers that why people still do not enroll, and why people have lost trust in the system. It's not going to work. Doctor is just going to give me Panadol. That's it. You know, I do have Panadol over the counter. I'll just buy it. So that is how the people have lost trust in the system is a very important element at the same time. We need to understand the cycle of the people. Even my wife, we were traveling to work in the morning. She was calling, holding the phone from 8 a.m. to 8:45 or 8:50. After 50 minutes, their PHO answered her call because she was trying to make an appointment. And the appointment was 2.5 to 3 weeks away. And she was saying, oh my gosh, okay, just give me repeat prescription. And they said, okay, yeah, that will be sent it to your pharmacy. That's okay. So this is the kind of system we are dealing with, right? So there are lots of challenges, lots of barriers, and they are increasing day by day. I was in the impression that the barriers should decrease. But no, what we are hearing from the people, what I hear from various Asian moms we work with, what we hear from other ethnic Asian subgroups, Thai, Cambodian, they're not even there. No one is even talking about them yet. So there's a huge system block, and willingness is not there yet, Trish. Sorry to say, but that's the reality.
Thanks, Vishal. I appreciate that.
Yeah.
And a harsh reality it is, isn't it, Vishal? I have another question for you. This is from Sione. What can the health promotion community, both the workforce and providers, do to help address the health and well-being of our Asian communities and families?
I think very good question. I think that was the last layer I wanted to explain. One is political, another is bureaucratic, and third is you and us, right? Health promotion community. So whenever we do and deal with our communities, my just 2 cents is I always request everyone to use that diversity lens, although it is not anywhere in your plans or in your strategies or in your how you deal with the community. But I think I will encourage every one of you to use the diversity lens. Diversity, when we call about diversity of everything, cultural diversity, linguistic diversity, respect, very common factor. If you feel respected, although you may not know the language, people can sense that respect, right? How you look at them, how you look at your audience, how you look at your clients. So I think strategically, we need to start responding it respectfully to our communities. And we need to acknowledge, yes, that we are not the people who know everything. We don't have solutions for every problem. But I think we need to start working together more with the Asian communities in our Asian settings so that the trust is rebuilt at some point. so that this is what we can work together. The second thing we can work together collectively is to start working together. Start working together with the Asian providers, and Asian providers should start working together with Mari Pacific and other non-Asian service providers, so that we can learn from each other culturally, and of course linguistically will be taken care of automatically. So these are the very practical things I can quickly think of that we all can do, but we still need a strategic direction how we can do that. Otherwise, again, after 4 or 5 years, we'll be talking about the same things, same issues, but they will be much more elevated. Yeah.
Thank you, Vishal. Just one question for Dr. Wu. Dr. Wu, based on your experience working and researching with the Asian communities, what are some of the strengths and successful initiatives within the Asian communities that we can actually learn from?
Yeah, thank you for your question. I think I have to say there are very limited research for our Asian community in New Zealand. So for example, the New Zealand Health Survey is really good to give us a very overall picture of what is the health status of Asian community in New Zealand, but it's not able to tell us what is the potential drivers, as those questions ask. What is the drivers for obesity? What is the modifier factors for obesity? I mean, we know quite a lot of research done overseas. Their potential drivers could be healthy eating, like activity, but we don't have research support in our New Zealand context. I think that's also point some potential research point, because as a researcher, I think that's really important to use our New Zealand context to explore what is the potential drivers, what is the modifiable factors for those issues already identified like 10 years ago. What can we do to in the research to raising those modifier factors to people, let them know if you realize you have obesity, you can do 1, 2, 3, 4 to reduce your health status, improve the health outcomes for Asian community, also for more than Pacific community. I think the logic will be very similar from a research point of view. We try to identify the different health needs for different ethnicity, and we try to use our New Zealand data to find out what is the modifiable factors for them, what is the most effective interventions for them, and try to promote those interventions, let people aware, oh, this is a problem, this is the potential solutions for the problem. Yeah, I think that's my very brief comments on that. Thank you.
Yeah, I would thank you, Dr. Wu. I would like to add just a couple of more points. We definitely need to have a lot more research done in this sector. That is why we are advocating for having to HRC to have a ring-fenced Asian health funding, so that our Asian health researchers can utilize that opportunity to do more research. But again, when we go to the decision makers table, they turn us around by saying, oh, we need more data, we need more research. But I would like to again reiterate, we have enough data available to start doing something and responding to the Asian health needs. I will give you an example, because I've been in the sector for quite a long time now. Couple of the initiatives that has worked really well within Asian communities was a HIHA project that was during 2007 or 2008. That was a locality called Pukitapapa Local Board. In that locality, ADHP funded a very small project in collaboration with the University of Auckland and TANI together to do healthy eating, healthy activity. That was called HIHA initiative. But it was a very small duration of the project, and it was done and dusted in 1.5, 2 years time, and that was gone. So these are the kind of things which we really wanted to have continued. We wish to have that these kind of things have continued. Otherwise, we are not going to see the change or the behavior change within 1 or 2 years' time of that particular community. So it was just a teaser. But if the appropriate resources, appropriate intervention would have been done, that time, I think the health of that community in that locality would have been improved for sure, because they were working with local businesses, especially the food joints around the area. They were working with Healthy Pukita Papa was another one, which came 7 years after that particular initiative. There was a long gap in between. So, these are the strategic things. If they would have made the decision to have Healthy Pukita Papa, healthy eating, healthy activity together in a cohesive manner, then that would have we would have got a better results for our communities. Another initiative I would like to mention is a ball screening project, Enroll with the GP project, that was led by Waitemata District Health Board. So there was a dedicated team employed to encourage people to have ball screening. And the uptake, when those people, those coordinators, multilingual coordinators from different Asian communities were working solely with the community, the uptake was very good. 1.5 years, there was very beautiful uptake. But once the positions were disestablished, resources were gone, the scale dropped drastically. So the ball screening numbers went down. So that is another a great example that having a culturally appropriate services for Asian communities do work, but you need some sort of commitment and the resourcing and the strategy behind it. Another example is Enroll with Your GP project that was also led by Waitemata District Health Board. And why I'm giving you these examples, these are the iconic projects that had some kind of a thinking and the resourcing behind that. So what we are talking about rest of New Zealand is no plan, no strategy, no resourcing, nothing. So these are the things I think we need to work on as a way forward.
Thank you. Any more?
Sorry, Lavinia, I talked too much. Sorry, apologies.
It's all right. All good. Back to you, Sione. There don't seem to be any more questions from. I think I have one more question. Again, it's from Trish. Do we have time, Sione?
Yes, go ahead as a
All right. One
last
more
question, perhaps.
So Trish says, many thanks to both presenters and to the Health Promotion Forum for arranging this kōrero. If there is anyone present who would like to connect regards, sorry, it's not a question actually, so everybody can read it in chat. So anybody would like to connect regards access dialogue regarding palliative care services for their community, whaiora. That's from Trish. My next question was going to be where to from here, but I think you've answered that, Vishal. Over to you, Sione.
Let's ask that last question, Lavinia. Where to from here, Dr. Wu and Vishal? After this report, what your team is planning to have next, and who do you see as people to engage further with, to see some actions, after the report?
The people we identify, Sione, to work with at strategic level, they go. So the health sector is restructuring so fast. By the time we identify the key people and they move on, and then the other thing happens. So we are waiting until everything settles a bit. But definitely we have had good kōrero with the health sector in Wellington and in our regional commissioner as well. So they are very well aware of the issues. Rather, they were at the launch of the report day as well. But again, there is nothing coming through because they are restructuring the teams. New team members are coming. So we are hopeful, fingers crossed. We are hopeful that something will happen very soon to address broader Asian health issues. But at this stage, we we can't see anything, but we will keep pursuing our intention with the commissioner and also in Wellington. But apart from that, I think we will keep working and pushing and encouraging and advocating for broader, better Asian health outcomes. Yeah. But I think we would love to hear from your strategic perspective, Sione, from Health Promotion Forum of New Zealand, how you can be part and embrace the Asian community and the Asian issues and Asian health into your foray, and how you can influence the other sector people, the decision makers, to make a informed decision. We are not saying you do this, you do that. What we are saying, you must use that lens of equity when you talk about Payora's key principles. Are we really following that? These are the broad-ended questions we need to ask ourselves and to our decision makers. But I'm just passing the ball to you, Sione. You suggest us, guide us from your perspective, from Health Promotion Forum's perspective, what else we can do.
Yeah, thank you for passing back the buck to me and our team, Vishal. But yes, certainly we would like to continue our collaboration. Health promotion is about working together. It's about the community and all key components of the communities. The state, the organizations, public sector, private sector, community sector. And certainly for the Health Promotion Forum, it's in our constitution to serve all communities and focusing on particular groups because of high needs, because of rights to health, and because for Maori, it's tangata whenua. And this workshop is part of that in our effort to work closely with you. Certainly, we will look into the future for more opportunities for this. But I would like to add what you said about the Waitemata DHB. There is no longer a DHB there. It's Te Whatuora, North Shore, and the wonderful work that its former CEO, Dr. Dale Bramley did. One thing about him, he was very comprehensive and cares for everyone in his leadership and delivery of the service. It was not just the Asian community. He covered the Maori community really well. As you know, he is Maori, but also with the Pacific community, and of course, mainstream North Shore. North Shore is increasingly diverse, and there is a high percentage, as you know, Vishal, of the Asian community here. And the leadership at the time, Dr. Bramley, acknowledged that two things. One is the workforce should reflect the profile of the community. And two, serve everyone, not just equally, more importantly, equitably. And, my experience over the last 20 years, observing, it's whether you cut it by needs or describe it by ethnicity, it's still the same. It's very clear those distinct population groups who are at the bottom of our socio-economic risk. I was in Australia last week at the annual symposium of the Australian Health Promotion Association, and it's very heartening to see that they are trying to move forward the health promotion community there, addressing the inequities that is very, very glaring in the Australian community. And I'm speaking about the Indigenous peoples of Australia versus the rest. In 2011, I participated at the same conference, and there weren't any presence, hardly any presence in terms of speaking workshops and policies, mentioned. But it's wonderful to see forward. But not disheartening when they reflected on how we are sliding back here in New Zealand. But let me get back to you for any final words before we close our workshop this morning. I'll start with you, Dr. Wu. Any final words from you?
Yeah, I mean, thank you very much for giving us the opportunity to advocate our research. I think that's a really important step. You know, in the traditional life cycle for research, we always end up with a publication or report. I think we should really push that forward to let people know what is the action steps after the report, after the research paper. I think that's really beneficial for us as a researcher, also for our Asian community. Thank you for giving us the opportunity.
Thank you, Dr. Wu. And Vishal, any final words from you?
Yes, Sione, thank you. Thank you. I will reiterate what Dr. Wu has just said. Thank you for giving us the opportunity today, as you have always done, Sione, for the broader Asian community. And I would like to acknowledge Health Promotion Forum as long-standing collaboration with Asian Network. I go back to the days when we physically have gone to Christchurch and to other regions to do the Asian cultural competency workshops. So I think we would love to see that happen maybe next year once everything settles down a bit, so that the flavor, the momentum is maintained in those regions, because the Asian population is quite growing in Canterbury. It's the second largest, and followed by the Central, then the Wellington, then Waikato. So I think there is a lot of Asian population is increasing in such regions. So we need to continue working together. So thank you once again, Sione and the entire team, for giving us the opportunity. Where to from here, as I mentioned, we are all in the same waka together. Let's keep working together with the good faith, good humanity and trust with each other. Thank you. Thanks.
Thank you, Vishal, and thank you, Dr. Wu. No, thank you for accepting our invitation to co-present today. And thank you to our participants who I've noticed that some might have left already, but this video will be available within 4 weeks on our HBF YouTube channel for public access, and that will help to promote our conversation today. And thank you again, everyone, for attending.
Thank you, Sione. Thank you. Thanks.
If you stay behind, we will take a photo for those of you who'd like to join.